Right. Well, good afternoon, everyone, and welcome to this week's edition of the DBS COVID presentation, our weekly webinar that tries to keep you informed during these uncharted waters. We are excited today to have with us Dr. Robert Frank, Medical Director from LIBRA Insurance, as well as coming back to our presentation once again, Lori Walker, our Chief Underwriter from DBS. The topic today is all around underwriting, the past, the present, and the future, and really what's it all about. But before we get into our content, I want to give you a couple housekeeping tips. First of all, for those of you that have not joined us in the past, make sure that you feel free to ask questions throughout. Well, not verbally ask questions, but in the Teams app that you all logged into, there is a comment section, and in there you can send a chat question to me. I will see that and do my best to ask Dr. Frank or Lori during our presentation your question. Dr. Robert Frank is, as I said, Medical Director at LIBRA Insurance Partners. He provides assistance with medical conditions and inquiries throughout our BGA organizations. He is board certified in internal in insurance medicine. He's served in numerous committees and has extensive experience in the role of a medical director. He served at one point as Chief Medical Director at Emeritus Life Insurance Company and is past president of the American Academy of Insurance Medicine and the Midwest Medical Directors Association. He resides in Ohio and in Florida. He is a graduate of Ohio State, Baylor, and Mount Carmel Medical Center. Dr. Frank, welcome. We're glad to have you with us this afternoon. I'm going to let you kind of kick it off. I think one of the biggest things facing us right now, obviously, is COVID-19. And I know you prepared some remarks. Can you give us an understanding of really what this virus is?
I'll be happy to, Kurt, and thank you for that kind introduction. If you look at that first slide, and I apologize, there's already a typo there. Corona spelled C-O-R-O-N-A. That's my fault. But anyway, what is coronavirus 19, which we refer to as COVID-19? Well, it's a single-stranded RNA virus. And if you want to really get to know COVID, then look at its cousins, okay? So its genome sequence, as you can see, is 96% identical to various bat coronaviruses, and it's 80% identical to the SARS coronavirus that struck the world in 2002 and caused a pandemic. So where did this come then from? Obviously, its genome sequence is very similar to bat viruses. So viruses are normally species specific, but all you have to do is have that one antigenic change, allowing that virus to jump species. So that's what's happened probably in this case here. You've had a change in the bat virus viral antigenicity, okay, making it enabling it then to attack humans, which it wouldn't have been able to do without that change, okay? And as you can see too, the coronaviruses are widespread in both human and animals. And so there's lots of different animal coronaviruses that, if with the necessary antigenic changes, could make this jump into becoming human pathogens. And we've had experiences with coronaviruses too. As we've already mentioned, in 2002, there was an epidemic called the SARS, the sudden adult respiratory syndrome caused by a coronavirus. And then in 2012, there was the Middle Eastern respiratory syndrome, MERS coronavirus. And then, of course, group 2 coronaviruses have been around for forever, basically. They're one of the more common causes for the common cold. So in addition then to being exposed to coronaviruses for a long time with the common cold, this COVID-19 epidemic now, pandemic, is the third one to strike in the last 18 years. I'll say a few words about the spread. If we could just maybe move to the next slide, please. There's a lot of talk about how this thing is spread, but basically from a clinical standpoint, it's droplet. It's person-to-person droplet. being able to isolate a virus from a package, from a doorknob, from a gas station handle is one thing, but that being a real mode of clinical transmission is very, very unlikely, okay? Because there is a thing called concept of inoculum load, and that's not only important from a person actually contacting or contracting the virus, but also about the severity of it too, okay? So again, you could isolate a few copies of a virus, maybe from the gas station pump handle, okay? But that would not be enough to cause a clinical infection, okay? But a lot of researchers are thinking that the greater the inoculum load, the more likely you are to catch the infection, and the greater the inoculum load, the more likely you may be to get more serious infection too. So this goes back then that the best way, or not the best way, but the way people have been catching this is from person to person with droplet transmission. So being in close contact with somebody who's coughing, sneezing, etc., and you're exposed to their droplets, then you're going to catch the infection. The typical incubation is 5 days, but as we've seen in these 14-day quarantines, that in some cases it's more prolonged and can be up to 14 days. But the vast majority of people will start to become symptomatic 5 days after catching the virus. And then the last bullet on this slide too is the one that's most important, because many people with COVID-19 are either asymptomatic or minimally symptomatic, but their droplets still contain the virus and they're still contagious to other people. And that's the reason we've had so much spread, simply because of this. If it wasn't this way, we probably wouldn't be in the predicament that we're in. You can go to the next slide if you need it.
Yeah, that's great. Lori, you want to, I think you have some questions. You want to jump into your questions?
Yes, can you go to the next slide, please? Dr. Frank, I know now that we have the COVID-19 now, just in the news today, it has surpassed over 3 million. But carriers and their postponed periods we've seen with COVID-19, we've seen a lot of carriers note that after 30 days, when we're talking about the incubation period, they will relook at somebody who has had COVID-19 after 30 days. But I'd like to know, and these are questions that some agents have asked over time, when is a person really considered clear? And what do you feel doctors and the life insurance industry will look at down the road to make sure someone is completely cleared of the disease?
Well, people are essentially cleared of the virus when they become asymptomatic. Most people, let's take a person that actually becomes symptomatic. Okay? So 5 to 6 or 7 days, they'll start having the typical symptoms of fever, cough, etc. We all know the symptoms that they have. Later on, we're going to talk about that certain subgroup of people that are high risk for more serious complications. But if you put those aside for right now and just look at the typical case, the person within 4 or 5 days of becoming symptomatic, so now they're day 9 or 10 of their illness, they start to produce antibodies. As their antibody production kicks into high gear, and that takes about a week to 2 weeks to happen, as that antibody production increases, the viral load decreases. So most people will have cleared the virus within about a maximum of 2 weeks of when they first became symptomatic, because by then their IgG antibodies are being produced, the virus is cleared, they start to feel better, and everything is okay after that. I mean, I think waiting 30 days, there's nothing wrong with that, except it's probably a little conservative, because most people that are mildly symptomatic, if you test them 2 weeks after the onset of their symptoms, when they're basically symptomatic or symptom-free at that moment in time, you will not be able to isolate the virus from them. So waiting another 2 weeks is just being extra, conservative or cautious. But most people do not take that long to recover.
Yeah, and when we are looking at that, it is something where we're looking at possibly additional testing or going to their doctor. There also are reports of people fighting COVID for weeks and even months. So what do you feel the average length of time, though, for them fighting the virus is? And if we have that 30-day window, is that really true to form when you're looking at the overall picture?
Well, you have that high risk group of people, which later on there's a slide about that, the diabetic, the elderly, but these people don't mount the normal antibody response that a younger person may, okay? So if they don't mount that antibody response, yes, they're going to carry the virus for weeks, okay? So these are the people that end up, though, in the hospital, in the intensive care unit, on a respirator, okay? That's a different class of people. Most people don't fight the virus for this long period of time. So I think you can estimate how long they're fighting the virus just by looking how long they're symptomatic, okay? And in that high-risk group, this thing may go on for several weeks, to even more than a month, okay? But again, the average person is going to be they're going to test negative for the virus. Their viral load will be negative 2 weeks after they first become symptomatic. Now, it takes them 5 or 6 or 7 days to become symptomatic. So you're talking about 3 weeks from the time they were first exposed to the virus. They should be clear.
So does it make a difference then, Dr. Frank? Would it make a difference on testing? So I've heard of people having additional COVID tests and having numerous tests. So maybe the first test was negative, and then they had another one done 7-10 days later, and it did show positive. So is that the reason that we are having that type of incidence as well?
Well, that just has really to do with the accuracy of the test, okay? You look at the people performing the test, the handling of the test after it's taken, do you have an oral swab, do you have a nasal swab taking, et cetera? What's the transit time? How was that specimen handled? How good is the laboratory? People that test negative, that are symptomatic, that test negative, and then later on test positive, and you heard these reports about people doing that. They were positive, then they were negative, then they were positive. That's because that middle test that was negative wasn't accurate. It was a false negative, okay? Again, most people, once they become asymptomatic, have cleared the virus, and those people are always going to test positive, or I'm sorry, always going to test negative, But our tests are not, both the antibody test and the PCR testing for the virus, because it's the way it's not being done in clinical situations in a hospital, et cetera. It's being done in parking lots and by people that have only been trained for 2 weeks to do it, and the handling of the test. So, the false negative and the false positive rates of these tests are not as good as we would like them to be. And I think that explains most of these discrepancies that you hear about in people and that you're talking about.
Yes, and that makes it scary, because it's like if you really are positive, then it's whoever you come in contact with and whoever they come in contact with, and so on and so on. Why are there so many contradictions and additions to the disease? What I want to ask you, Dr. Frank, is the fact that when it first came out, we were noting that it was the elderly that had comorbid conditions, and even the comorbidities as time has gone on have changed somewhat. We have obesity was added into the mix after a while. I've heard of low vitamin D or being added afterwards as well, when they were talking about certain communities really being affected by the disease. Do you think that we really have a handle on what it really is? Or I feel like there's always been some contradictions on the first amount of information that's come out and how the disease has kind of progressed over time. What do you feel about that?
Well, I think the biggest problem is this is a new virus, as we talked about. Okay, we've not had exposure to this. We've never had any ability to study it, et cetera. So we're learning as we go. And I think all the contradictions have simply come because we were learning on the go. Okay, so 1 month into the pandemic, you had this amount of data, and so you made estimations, and then 6 weeks later you have more data. I don't think there's really been any real contradictions from my standpoint. I think it's just we're learning as we go, and the more we learn, the more accurate information we can give. So, and everybody across the world is studying this thing. So everybody's looking at this virus from their own unique angle. So they're looking at it from this standpoint, that standpoint, and everybody's tossing out their own little 2 cents worth as they go along, and how much of that stuff will bear fruit as we go on, and it's further study too, but I don't think there's a lot of contradiction. I think the basic stuff that we know about the virus is true, has always been true, and stayed true, and we haven't varied from that. And I know there was something on here about like wearing a mask, not wearing a mask.
Right.
Nobody ever said wearing a mask wasn't helpful, okay? We know that droplet is the main form of transmission, so what can you do to decrease droplet transmission? Well, you can wear a mask. Now, you can argue about how much it helps. Does it help 20%, 30%, 40%? That's debatable, and we'll learn more about that maybe as time goes on. But anytime you can cut down the person that has the virus from spreading their droplets around, you're going to have some benefit. Okay?
Right.
Dr. Frank, this is Kurt. We have a question from our audience that I just want to insert here real quick. If someone contracts the virus and is symptomatic or not, can they contract it again? And do we know if the symptoms would be less severe the next time round if they would contract it again?
Well, the second part of the question, I think the answer is we don't know. Can somebody contract it the second time? Right now, again, that answer is unknown too. We know that vast majority of people start to produce antibodies within 5 to 7 days of having the virus attack them, okay? And by 14 days out, they've got good antibody production. The viral load starts to decrease. They start to become asymptomatic. Now, what we don't know is how long that immunity is going to last. And later on, I have a couple of, a bullet point about that. Because this, again, is a new virus, we don't know, is this virus going to act like the common cold virus, which gives you limited to no immunity in the future for the common cold again? Or is it going to act like an antibody production to another virus, which may last your lifetime or last years and years? So from a theoretical standpoint, then yes, a person could get it, and then a month, and they clear it, and then a month later, contract it again. That is theoretically possible. How would you explain it? You'd have to say that their antibody levels weren't protective. They didn't stay high enough or weren't strong enough to prevent the infection. But the other possibility in somebody like that is they really never cleared the virus for some reason too. So then that goes back to, you say, well, they tested negative for the virus. Well, what was the accuracy of that test? Could that have been a false negative? So, and on individual cases, sometimes you don't really, right now, we're still not going to know all the answers. My guess in that person, it would be their immune response did not give them protection in the future. Okay. Just like some people catch 3 or 4 colds in a winter, and some people catch none. Why? So that's my best answer there.
All right, thank you.
Any other questions? If not, maybe we could move on to that next slide where it talks a little bit about clinical infection.
Yeah.
You bet.
We mentioned about this virus made some sort of antigenic change, and that antigenic change was it made that virus able to attach to the ACE2 receptor sites of human cells. We find ACE2 receptor sites in the upper respiratory tract, or nose and sinuses, our lungs, heart, kidneys, and our endothelial cells. The most important in terms of the actual disease and making us sick, though, has to do with the lung, okay, with the ACE2 cells in our lungs, and it attacks both the type 1 and type 2 alveolar cells. Type 1 cells have to do with oxygen transportation back and forth, and type 2 cells make the surfactant that keeps our alveoli or our air sacs open. So you can see if it's killing the cells that do oxygen exchange, and it's killing the cells that produce surfactant to keep our air sacs open, okay, we have collapse of airways and no oxygen being able to be transported, go from the air into our red blood cells. You'll get adult respiratory distress syndrome, okay, and that can happen very, very suddenly with respiratory failure. Because it also affects endothelial cells that found in people, the sickest people, okay. A lot of this came from people when they did postmortems on them. There's also a microangiopathy with microthrombosis, and that's especially severe in our lungs, so that even complicates the ARDS. And then some people, again, become so overwhelmed with the virus, they have what's called a cytokine storm, and those people end up with multi-organ failure. So not only their lungs, but their kidneys and everything else can become diseased. And we've already said before, the majority of people are asymptomatic, okay, are asymptomatic. And this list started out with just maybe older age, but it seems to be there is increased risk for having more severe disease, with more severe lung disease, hospitalization, intubation, with older age, obesity, diabetes, hypertension, coronary artery disease, chronic kidney disease, and chronic lung disease. And those have been pretty much shown to be true, I think, across the board. But every day people are finding maybe other things that might make you more susceptible too. Also, we already mentioned about vitamin D, et cetera. But these are the main ones, okay, that give us an increased risk of having a more severe infection. And that's why. Go ahead.
I was going to say, we had, finish your comment, and then we have another question that's come in from our audience.
Mm-hmm.
The question is this: as you're talking about this, we all hear in the media every single day reports about ICU capacity, mortality rates, the number of cases. As a medical professional, and actually more importantly, in a medical professional focused in the life insurance industry, what do you think is most concerning to insurers right now, and what should be most concerning to our advisors as they're working with their customers?
Well, if I put on my medical director for an insurance company hat back on, you have these people, older people, and so many of them have diabetes, many of them have hypertension. Those are people that are standard. Many of them even qualify for preferred rates, et cetera, depending on the control of their blood pressure and et cetera, like that. And you take them and with their life expectancy, well, they're going to live, 10, 15, 20 years. They're only 60 or 65, and you have disease that's spreading rampantly across this country that's going to, it's already killed, over 100,000 people now. And so you're going to have all these people that you expected to live a long period of time that are going to suddenly be cut short in their life. And so I'm certain the actuaries are scrambling around trying to figure out, what kind of damage is this going to do to us? Do we even want to take? I mean, I could see them saying, listen, if you're over 70, or you do have diabetes, or you do have some of these other things that we would normally take, lung disease, okay, mild COPD or mild asthma, we're not even going to take them for anything more than $50,000 or something like that, because we can't stand the risk of insuring these people for millions of dollars, and then 6 weeks later they're dead because of this pandemic. So
what if you take your medical director hat off and just speak of it as a medical professional then? of those different statistics that you hear, the number of cases, the ICU capacity, or mortality rates, which ones concern you the most?
Well, the biggest concern with this is two things. This virus is much more highly infectious than a lot of other viruses around. You know, I've heard people say this is just a bad case of flu. It's not, okay? It's much more infectious than the influenza virus, okay? And when it really hits people that are high risk, okay, it does much more damage than the flu virus does. And people then that become sick enough to go into the hospital, those people, I mean, 10% of people that go in the hospital end up in the ICU, and most of the people that end up in the ICU do not make it out. So, and that's what's overwhelming, you know, the hospitals and their ICUs, et cetera. And from a clinician standpoint, and there's no treatment for these people. I mean, supportive, you know, we talk about we have no effective treatment. It's all supportive. So you're sitting there just trying to keep the people alive, hoping that their immune response will kick in. And it's got to be very frustrating for the clinicians taking care of them. So that's my comments. So yeah, here's about treatment. You know, there's no effective treatment that's been proven so far. Okay, so right now the treatment is basically supportive. In the sickest people, supportive means that you're on a respirator. And if you get on a respirator, you have less than a 10% chance of probably making it off of a respirator.
Yeah, and Dr. Frank, you had alluded to this earlier. So we have seen a shift in life insurance, you know, in our industry for sure. And you touched on that, which was a great synopsis of what is going on in the industry, which is older individuals, some carriers pulling back and not offering over age 70. Some carriers are only going to a low table rating to a, you know, on certain individuals and not even allowing to go up. We used to be able to get cases table 8, table 10 in certain circumstances. And now we're not being able to do that. And I think part of that also, when you talk about actuaries, is the system trying to catch up with this disease and figure out what their entire mortality is going to be on a global scale, because we have reinsurers that have global involvement, not just USA involvement. So when you're talking about as a medical director in your former life, do you see that hopefully at some point, will that change at all?
Well, I think it will, but I think you're going to have to wait for this pandemic to basically die down. And that's going to be, I think, well into the middle part of next year. And, you know, and in saying that, I'm predicting that we'll come up with some kind of a vaccine that will have some benefit. You know, whether or not we develop a vaccine that is totally protective for a long period of time, or we come up with a vaccine that'll give you a year's worth of, you know, benefit, similar to what with our flu shots we get yearly. It's really unknown, but I think it's going to be like this way till the middle part of next year. And again, I can see insurance companies, like say, you have somebody with some chronic lung disease that based upon their pulmonary function test or whatever, they were a former smoker, they don't smoke now. Okay, this person's 2 tables or 3 tables. I can see them saying, we don't want anybody with chronic lung disease, you know. We don't want anybody with diabetes of long duration and age 70, at least not for large amounts of insurance.
Right.
And I can see that going on till next year.
Yeah. No.
Any other questions right now? We could just jump to that next slide about recovery too, and we've kind of touched on a few of these things. Everybody still there?
Yep.
Yeah.
I think so.
That slide that says recovery, maybe my computer I was looking at the slides, but now I don't see a slide. But anyway, when we talk about recovery, I said within several days you get IgM, and then within several more days after that, IgG antibody production. And as the antibody level increases over the next couple of weeks, the viral load decreases, and then that person becomes asymptomatic and basically is cured of the disease. And they're not infectious to anybody, and they should be able to get insurance at that point in time too. The big unknown with recovery, and this goes back to the vaccine development too, is the durability of the COVID-19 antibody is unknown. So go back and look at its cousins. If you look at SARS antibody production, it stayed strong for about 6 months, and then it rapidly diminished. So many people 1 year after if they had SARS could actually catch SARS again, okay? If you look at the Middle Eastern respiratory syndrome, the MERS, okay, antibody levels for that were much more prolonged, went 3 to 4 to 5 years. So a person that had that, they would have been protected for that disease for a long period of time. But then if you look at the type 2 common cold, there's no long-term immunity at all. So we don't know what the durability of the COVID-19 antibody is going to be. You know, hopefully it'll be more like the MERS, where the person will be protected for several years. But we really don't know the answer to that. And that kind of makes it scarier in terms of, you know, talking about the pandemic and talk about insurability too. It's also important in looking at that, how effective is a vaccine when we finally develop it? How good is the vaccine going to be? So, and then I did have a few comments about just underwriting in general, though we've been talking about that. From my standpoint, if somebody has had COVID-19, they were not hospitalized, so they had an asymptomatic to mild to type of case, they should be insurable within 2 or 3 weeks of when their infection goes away, okay? And you know, so the insurance company is saying, well, you have to wait 30 days. I don't think that's unreasonable, okay? And they should take no adverse action on that person at all, okay? However, if they were sick enough to be hospitalized, you know, that's a different story, okay? Because those people may end up with some permanent damage, okay? Permanent damage to their lungs. There's new reports now about some of these people have CNS changes that take months and months and months to go away too. So I could see a carrier, if somebody's been hospitalized, postponing these people maybe for much of a longer period of time, 3 to 6 months. And even at that point in time, they may require additional testing at that point in time to prove, you know, that what kind of recovery they have made. I know people don't do pulmonary function tests anymore, et cetera, but I could see PFTs making a comeback in the future if you're looking at somebody that was hospitalized with COVID-19 and what is the status of their lungs when they do go to apply for insurance, you know, down the line.
Yes, that's what I was going to ask you, actually. Do you see, you know, because we don't know the overall extent of what the disease does do to somebody, you know, to some individuals. We just saw that Nick Cordero, a 41-year-old, just, you know, battled the disease for 95 days and had blood clots and ended up passing away. So you did answer that you know, it could be a possibility that part of that is to send someone for a pulmonary function test, which opens up a whole new can of worms, whether or not examining companies will do those, because those tests sometimes, you know, you have to have explicit instructions on how to do those to get a positive result on some of those tests. But, you know, do you see that possibly then as a former medical director coming back in those circumstances?
You know, I could. I think that anybody who's hospitalized is going to be underwritten more carefully in the future. Okay. Of course, there's other things that you can, you know, if you're trying to, you could say, well, listen, this person is back and they're running 2 miles every day, you know, and they're back working full time and you know, they're asymptomatic. So you could argue they don't need PFTs if they're able to go out, you know, or they went and had a treadmill stress test done and they went 9 minutes, you know, on the treadmill. Well, it doesn't make any sense to do PFTs on those. So you might have to do some kind of other roundabouts to show this person has recovered fully and doesn't need to have PFTs or anything done.
Yeah. Do you see insurance companies doing COVID antibody testing as part of their regular testing for insurance labs? I know they're working on some of the tests. I know those tests are not 100% reliable at this point, but do you see that possibly happening down the road?
You know, it's not unreasonable, and I simply say that because, again, think about it. We're still in the middle of this pandemic. You have somebody that has a mild diabetes that's 70, so they're in the high risk category, and they want to apply for, you know, several $1 million worth of insurance. So the insurance company is going to be concerned this person could come down with COVID a month from now and be dead. And we have to pay the claim. Otherwise, we expected them to live 10 years. If they could show this person has immunity to it, okay, then you could say, well, they're not at high risk anymore. Now, the caveat there is, again, we still don't know what that antibody means, but right now, most people are thinking, in general, if you have a nice, strong antibody response, and you can measure that in a test, then they should not get it in the future. And so you could use that to your, I think that would be a good thing, to be honest, okay? I think if they did it, they would find some people that are not immune, okay, so they're no worse off they were. But if their test was positive, then you could argue with the insurance company, well, listen, they actually had an asymptomatic case and they have immunity now. So they're not, you know, they are not going to get sick and die 6 months from now prematurely. So I think that would be a good thing.
Right. Use it as a predictor.
I would you know, again, if an actuary came to me as a medical director of a company and asked, do I think we should do it? I would say yes. You know, that gives me another piece of important underwriting information.
Yeah. Yeah.
And as far as the reliability is good. I mean, all tests can have false negatives simply because of the antibody level, but things that are done in insurance labs, because they're done by people that are trained, you know, specimens are sent overnight, they're processed properly, the tests are done in quality laboratories with quality reagents, you're going to get as good a result with that as you would with any kind of testing that we do for anything else, you know, HIV disease, et cetera.
Yeah. Yeah. Well, with the number of cases, and do you feel like there truly is a surge of the disease? Or, you know, we've had a lot of people that said, well, of course there's a surge. People are just doing more testing. And when we are talking about ICU capacity, I mean, to me, I've always said I look at the ICU capacity in whatever state you're in, and take that as a true surge as opposed to just numbers if there is more testing. And do you think we've even hit the second wave, or are we even there?
You know, to me, we're still in the first wave. In a way, doing testing finding more cases with testing and is all one and the same thing. I think the virus has been around, infected a lot more people than we ever imagined before. Okay. However, early on, if you go back, you know, February, March, and April, the only people we were testing were people that were symptomatic, the really sick ones. Okay. Nobody was testing, you know, younger, healthier people, et cetera. So I think, you know, the positive test to me just reflects the fact that a lot more people have been infected over the last several months. We just didn't know it because we weren't testing. But your comment about is well taken, because there's a difference between how many people are testing positive, how many thousands and thousands of these asymptomatic people, you know, are testing positive, versus the people that are sick enough to end up in the hospital. So looking at hospital rates and ICU admissions and ICU capacity is a good way of gauging the severity of the disease. And the more people that become sick, obviously, the more people are going to end up in the hospital. And, you know, and if you find more people, so you have all these young people, not to be judgmental, but they weren't practicing social distancing, they weren't wearing masks, etc. So they've been spreading this, this around over these last several months. Eventually, it reaches that vulnerable population, their parents, their grandparents, their aunts and uncles, everybody else. They go to, visit people in the nursing home, look what happened. So there's where we end up with that surge in the ICUs. And that's a good estimation of, how this is really, how long it's going to take us to come out of this thing. When the hospitalization rate starts to drop down and the ICU admissions start to drop down, then you're going to feel better about everything, regardless of how many other people are testing positive, okay? As long as the young and healthy people test positive, but they're young and healthy and they can go about their business and not hopefully not infect other people, but it doesn't affect their ability to work or, to carry on day-to-day activities, then you can feel like you're starting to come out of this thing.
Yeah. How far off do you think there is a vaccine? And, when we talk about vaccines, what worries me, it's just like the flu, sometimes that morphs and changes how it operates in our system and different strains. How far off do you think we are? And are you worried about it morphing and changing? So by the time we do have a vaccine, it looks completely different, and maybe we have another strain where that vaccine did not work.
Well, those are all valid points, and nobody really knows the answers to those things. One thing, but you can speed up vaccine production simply because you have to first develop what appears to be a vaccine, the viable vaccine. What kind of antigen do I inject into that person? What antigenic sites do I manufacture to inject into them to get an antibody response? You can speed that part up, and that's what governments around the world are doing, and that's just a matter of throwing money at the scientists and letting them do it. However, the part that you can't speed up is, okay, I have this vaccine and it's the right antigen, okay, that I'm going to inject in somebody, just like you get your flu shot, it's going to give me an antibody production. I got to find out if it's safe. Well, the only way I can do that is I have to inject, thousands and thousands of people and wait and see what happens. And then I have to find out, well, how effective is it? Then I have to wait and see how much, you can challenge some of those people, okay? But basically you have to wait and see when they go out into, society and go around, how many of them stay safe? Does their antibody levels stay up, and do they stay protected from catching it from everybody else? You can't speed that part of it up.
Yeah.
And that takes months and months and months. That's why I think that at the minimum, it's going to be the first part of next year for a reasonable vaccine. They might be testing it in the phases that they do, but as far as having antibody or a vaccine that's available to everybody, it's going to be sometime early next year at the very best. At the very best.
Yeah.
And right, the other part of your question was, you can produce a vaccine now and find out that as this virus morphs around and changes, it's antigenic, just like the flu does, that next year it's not as effective. Okay, so it is possible that you may end up with getting a yearly flu shot and a yearly COVID vaccine shot for a couple of years or something like that. We don't know yet.
Yeah. Well, the next slide that we have that we had talked already about the underwriting changes and COVID-19 impacts to our industry. And we have seen, carriers dropping the internal retention and auto binding limits. We've seen them offering max table ratings of table 4 or lower, getting rid of actual products that are offering over age 70. We only have a couple now that'll go to 80 and 90. And, limiting some of the morbidity conditions that we see where they might have somebody that has multiple comorbid conditions, and we're just not seeing underwriting be as competitive in that instance that we were maybe 6-7 months ago. We're also seeing a change on foreign travel Dr. Frank, I don't know if you know, but EMSI, as of last week, which is a huge company that we have utilized at times to do exams, they actually had an underwriting section where they did underwriting as well. They were working on electronic health records, and they literally closed their doors. They feel that, I feel like COVID-19 made an impact in their business and their industry, and all those individuals now are out of work. So we are seeing some impacts. Do you foresee any other things that would happen if this keeps on going in our industry?
I just think you're going to see more conservative type of offers and limited offers for certain populations for the foreseeable future. There's nothing that's going, which is bad news for for people that are out there trying to sell the insurance. But I can't see anything that's going to happen in the next 6, 9, 12 months that's going to make this thing go away to where everybody's not going to worry about it from an insurability aspect.
Yeah.
Which means if you have clients that are in this high risk population, you need to be scrambling around now as best you can to get whatever offer you can get now, because it's not going to get better in the near future. If anything, it's going to get worse. It's going to get worse.
Yeah.
Yeah, Dr. Frank, go ahead.
Well, I always just tell agents, they would be, when this is one of medical, they'd say, well, I don't want this table D, and I don't want this guy to go to this. I said, talk them into the table D, then go get your stress test. And if it comes back negative, then you can come back and say, okay, I want a better rating, okay? And if it's positive, guess what? You're way ahead of the game, okay? So take what you can get now, and worry about the consequence, getting something better later on. But it's going to be tougher in the near future on this high-risk people.
I agree. I agree with you.
Yeah, Dr. Frank, Lori, very informative. Thank you. And before we go into a couple of the slides for me to wrap up, I want to just point out that we see many offers here at DBS that people are kind of waiting on the sidelines saying, well, it's not convenient for them to fill out the paperwork to place it quite yet. We'll place it next week. We'll place it later. It'll be taken care of. And I need to tell you, just from the information that I heard in the last 45 minutes, if you have an offer, you need to place it, because if somebody gets COVID or is exposed and is in one of these high risk categories or not, you are going to be you're going to be a world of hurt, because if it went out and went to facultative or whatever it did, you're going to be set back another month plus before you're going to be able to go back in and see if you can re-underwrite the case and hope the person's better. So as Dr. Frank said, if you have a table 4 on somebody and you're wishing it would be better, the best advice right now that you should take away from this call is you should place that. And then we will work with you as hard as we can. We even bring Dr. Frank in from time to time to help us negotiate with Lori, with carriers, and talk about medical conditions. But it's better for you to wait to have us do that later, get the cases placed now. That's very important. Lori, if you'd go to the next slide, I want to just make sure that we just remind people of some of the things that you can do from a resource standpoint. And we have a number of resources that you can go to. We have the COVID-19 Resource Center. Lori just mentioned, just maybe 3 minutes ago, that some carriers are actually changing their retention rate. We literally just found out on Monday from one of the largest insurers in the country that they've lowered their retention rate. It's hard for you, it's hard for everybody to keep up on what all of that is. Go out to our COVID-19 Resource Center. That is all updated out there. We update it daily if necessary. If there's something to update, we make sure it's updated. So make sure you go out there, underwriting and paramedics information, et cetera. It's all out there. Make sure you keep yourself current on that. Then additionally, we continue to have updates going into our other parts of the website, including the pulse on the industry. Terry Getman continues to keep that updated. Obviously, COVID has been driving lots of changes at the congressional level, and this is important not only for your individuals, but for your business owners to understand what the impact of these various programs are and how you should plan for them. So make sure you check that out. Again, these are all located on the DBS website. You simply, to get to our COVID site, you don't even have to have a password. You just simply click on the red banner that takes you straight in there. And then our eSolutions resources, again, you can just simple term insurance right now. Simple term insurance using our Fast Term platform. You can have touchless underwriting or nearly touchless underwriting, depending upon which carrier you're using and the circumstances around the case. So make sure your clients are getting covered. Make sure they're getting the help that they need and the coverage they need, especially in this troubling time. All right, well, Lori and Dr. Frank, thank you so much. Any final words before we sign off today? Dr. Frank?
No, I just appreciate everybody signing in. You know, one thing did pop into my brain. When we kind of said this before, you know, would insurance companies start doing antibody testing for COVID as part of their routine test? If you had somebody that had a very mild case of this, documented because their test was positive, they recovered, and maybe they even went back to their doctor, and their doctor did an antibody test, and now it's positive, and the insurance company's giving you a tough time, you could take that positive antibody test and say, listen, here, I'm proving this person is, you know, you're going to take this post aspect. Listen, this person is now immune. They can't get it again, you know, and you can use that to maybe try and twist the arm of the carrier a little bit to go ahead with the underwriting process.
Well, I will utilize that for sure. Thank you for that information. I really appreciate it. I think for us, make sure that, you know, as Dr. Frank had said, these are tough times and things are changing constantly. So I would like to reiterate that at DBS, for the underwriting department, we'll do whatever we can to get the most competitive offer possible. But if your client comes into a situation where their health may give them a table rating, I would just like to reiterate it. Now is probably the time to take those cases and maybe take a lower face amount and sell those and hopefully have some coverage for your clients and do your due diligence to make sure they have something to cover them. And we can always come back after hopefully this pandemic is over and things change a little bit, but at least you're covering your clients in the meantime.
Good advice, I think.
Lori and Dr. Frank, thank you. We continue to see record amounts of insurance coming into DBS, and we thank you for that. But it also tells you that there is an increasing demand for life insurance more than ever before. Make sure you're utilizing all of your resources here at DBS. We're here to help you and help your clients. Until next time, be well and stay safe.
Bye, everyone.
Thank you.